My name is Dr.Pauli. I'm a professor of surgery at the Penn State Hershey Medical Center in Hershey, Pennsylvania. I am a minimally invasive surgeon by training, and about 50% of my practice is advanced therapeutic flexible endoscopic procedures. I got involved with the GripTract project about 2 years ago or so, and the main goals in my involvement of the project were to provide an understanding of what modern surgical endoscopy is about, to help develop a device that is useful not only for gastroenterologists who do EMR and ESD, but for surgeons who, for whom it's not part of their routine practice yet, with the goal of getting more people doing advanced polyp resections endoscopically and doing fewer of them with laparoscopic or open surgical techniques. I've had the opportunity to evaluate GripTracts in a variety of different settings over the course of time. What I like about the device is that it's adaptable to the endoscopic equipment that we already own. So anybody who wants to use this device can simply attach it to endoscopes that they already have. The fingers on the device are very intuitive to use. Left is left, right is right. It's a turn of a knob to allow the device to work. And I think that its main advantages in that regard are its ability to create areas of tension and countertension. What this device is capable of doing is not only producing lift, but allowing that lift to be dynamic and change on a minute-to-minute basis without really having to reposition or readjust a clip, to re-inject, to really do much else except turn the knob, which is immediately next to your instrument channel. And so that's a very, very helpful thing to have. And secondarily, there are actually two fingers, and so you can actually create tension not only opposite the wall of the GI tract, but between the fingers themselves. And so you have the ability to create tension in planes that are normally very different to create tension in endoscopically. So this is an ex vivo porcine model of some gastric tissue. And this is one of the first times that I had my chance to have my hands on the GripTract. What you see me doing is sort of two-handed retraction. So we're using the right finger to lift up on the mucosal flap that's already been started. And then we're rotating downward with the back of the left finger on the gastric muscularis itself. This amount of distraction is not possible in most circumstances. And again, we're doing this in a very open gastric model. You can see it's not even a lumen at this point. It's just a flat surface. And so we're not getting any distraction even with gravity or with insufflation. This is all distraction being generated by the GripTract fingers themselves. One of the things we also realized is that the fingers can actually be used to manipulate end effector tools as well. So we've actually been able to use our endoscopic knives, and by utilizing the fingers and rotation motion, rather than moving the endoscope across the plane, we can simply rotate the wheel, move the finger, and then use that finger to drive the tool across the plane. And so what you wind up getting is multiple additional degrees of freedom at the end of the endoscope that are not normally possible with standard EMR or ESD techniques. We know that it takes a large number of procedures in the submucosal plane before you are facile with doing it, speedy enough that it doesn't take all day, but also safe enough that you're not causing full thickness perforations. I think what GripTract is going to do is to really bring down that learning curve. It's going to allow more people to be trained in these procedures, to be trained with fewer procedures overall, which means more people can be trained in a shorter period of time. And again, as a surgeon, what I particularly like about this is the ability to allow surgeons, in particular colorectal surgeons, who may be referred patients with large polyps that have been deemed endoscopically unresectable, but to allow those surgeons to say, hey, I'm going to use this technology to assist me in doing a more complex polypectomy that anybody in the local area can do. And I'm going to try and do an organ preserving surgery rather than, again, a laparoscopic or robotic or open colectomy.